Good afternoon, Professor and Doctor. We will discuss diabetes and chronic kidney disease. Can we protect the patient with new medications? Chronic kidney disease and its significance, an economic and social burden, which costs an impact of around 10% of the general population worldwide. And when we look to the population on dialysis and the growth rate of dialysis population requiring treatment, it's supposed to be around 5 million in 5 years. And when you look to the chronic kidney disease needing dialysis, you will find that more than double of the current population on dialysis need more service for the logistic as well for the economic burdens on countries. And this rise is largely derived by population aging, the seniors peoples, and as well an increasing prevalence of diabetes and hypertension. And the prevalence of CKD in different populations with type 2, either with lower estimated GFR as well in patients with albuminuria in different countries, will find around 50% of those discovered to be diabetics in type 2 may probably have a CKD already. And diabetes and the kidney failure on the rise among seniors, with 60% increase in the number of seniors with kidney failure. And a lot of them is still acquiring diabetes, with increasing in number of seniors with diabetes. And this multiplier of chronic kidney disease as well in cardiovascular disease, increasing the mortality from cardiovascular diseases noticed in diabetic as well in patients with diabetes and CKD amplifier. So the renal dysfunction is common in patients with type 2 diabetes in all stages, and approximately 40% of type 2 diabetes show signs of CKD. We need an urgent need to invest in the management of diabetes as well in the renal replacement therapy. And we look to the pathogenesis in brief of diabetic. The pathologic process leading to glomerular injury and the proteinuria with hyperglycemia is a metabolic problem as well as the filtration problem with constriction of the efferent arterioles. So increased glomerular pressure is the leading cause as well for proteinuria. Fibrosis and nephron loss and the renal response to injury with vascular and tubular injury, glomerular cells, including cytokines, transforming growth factor beta, angiotensin 2, platelet-derived growth factor, tubular necrosis factor, interleukins, fibrosis. And the glomerulopathy in the diabetes, including the podocytopathy, mesangial cells as well substantially altered by diabetes undergoing proliferation and hypertrophy, while increasing their production of matrix protein, and finally, thickening of the glomerular basement membrane is present in almost all of the patients. So inflammatory cells recruitment in diabetes and tubular interstitial cells fibrosis in diabetic kidney disease is the hallmark of the diabetic nephropathy and the progression to CKD and to end-stage kidney disease. So diabetes and CKD crosstalk injury to vascular endothelium, with increasing inflammation in both the CKD and diabetes, augmenting the effect on different body organs, with increasing oxidative stress from uremia, inflammation, sarcopenia, and endothelial dysfunction, with several mechanisms of endothelial damage in diabetic, like inflammation, dyslipidemia. So let us think about the residual risk. What option do we have now? Current option with scientific literatures, an option to prevent new onset or worsening of the renal function using RAS blockade, decreasing intraglomerular pressure, using ARBs or ACE inhibitors. And now we can talk about the sodium glucose transporters in the field of the lowering and slowing down the progression of the CKD due to diabetes. So it's a multifactorial intervention decrease, but unfortunately did not eliminate the risk of the new onset diabetic nephropathy in patients with type 2. With follow-up in years, still there is residual risk of progression of chronic kidney disease. So CKD risk factors in general with diabetes could be classified as modifiable factors and non-modifiable factors like age, senior peoples, race, but we have to control the modifiable factor like diabetes, hypertension. So diabetes is always associated with ventricular remodeling, is characterized by left ventricular hypertrophy, inflammation, impaired cardiac metabolism. So sodium glucose cotransporter inhibitors may offer effect on several of the fundamental molecular as well cellular pathway involved in the pathogenesis of the natural history of cardiac failure in diabetes. The putative mechanism underlying sodium glucose transporter inhibitors in protecting the heart, improvement in cardiac pre and afterload, improving in cardiac metabolism, myocardial sodium hydrogen exchange inhibitor, reduction in cardiac necrosis and apoptosis, with alteration in cytokines and adipokines production. Considering the kidney with sodium glucose transporter inhibitor through the tubulo-glomerular feedback promote afferent arteriolar vasoconstriction, decreasing the proteinuria, and this turn serves as a mechanism to reduce intraglomerular hypertension and provide some of the nephroprotection. So the beneficial effect also extend to tubulo-glomerular feedback mechanism, inhibits proximal glucose reabsorption, blocks proximal sodium reabsorption, natriuresis. In addition to the downstream effect, decreasing urinary albumin excretion may reduce pro-inflammatory pathway activation and direct tubular toxicity, with some of the cardiac function improving the glomerular blood flow. So the potential effect by sodium glucose cotransporter inhibitors improve the renal outcomes as discussed, with improvement of the glomerular pressure, decreasing the glomerular hyperfiltration, neurohormonal effect improvement, decreasing inflammation and fibrosis, and decreasing renal workload and hypoxia. In vivo imaging analysis demonstrate afferent arteriolar constriction following sodium glucose transporter therapy. Very promising result. And when we look to the differences between sodium glucose transporters and diuretics, the advantage of sodium glucose transporter inhibitors may differently regulate interstitial versus intravascular compartment. And this difference may selectively reduce interstitial volume with minimal change in blood volume. So the evidence behind sodium glucose cotransporter inhibitor is deliver this benefit, and who are the patients will benefit more. In multiple studies considering different classes of sodium glucose transporter brands, seeking for the type 2 diabetes, cardiovascular disease, and or cardiovascular risk factors, like the CLEAR study, and CKD with type 2 diabetes or without type 2 diabetes, like DAPA-CKD study, and also with heart failure and type 2 diabetes, like DAPA heart failure. The primary outcome usually go through the cardiovascular complication or cardiovascular death, and with DAPA-CKD, the doubling of serum creatinine, renal or cardiovascular death, or the effect on estimated GFR. DAPA and cardiovascular outcome in type 2 diabetes, over 17,000 patients enrolled in this study, and DAPA effect on cardiovascular events show very promising results in a broad population of patients who had or were at risk for atherosclerotic cardiovascular disease. So it's eligible patients over 40 years and have multiple risk factors for atherosclerotic cardiovascular disease or have well-established atherosclerotic cardiovascular disease. Also, they had type 2 diabetes with a glycated hemoglobin at least 6.5%. The DECLARE study was an assessment of cardiovascular effect of DAPA in a broad cardiovascular risk population arms with either multiple cardiovascular risk and established cardiovascular risk disease against the placebo. The primary outcomes with cardiovascular death, myocardial infarction, stroke, and cardiovascular death or heart failure, with secondary endpoints considering cardiorenal composite endpoints, as well all-cause mortality. So DECLARE has the largest type 2 diabetes primary prevention population among sodium glucose cotransporter inhibitors. Comparing to other studies like CANVAS study, and DECLARE also showed good reduction to multiple risk factor patients. So DECLARE demonstrated cardiovascular safety with Dapagliflozin in this broad cardiovascular risk population earlier in the cardiovascular risk continuum. DAPA also slowed renal disease, considering the renal composite endpoints against the placebo. And it showed that in analysis, DECLARE studies, DAPA demonstrated a significant reduction in the occurrence of the renal-specific composite outcome. So DAPA showed that reduction was seen across all clinical important components of renal-specific composite, including end-stage and renal death, including secondary renal composite outcome, renal-specific outcome, estimated GFR, as well individual components. In the meantime, urinary albumin-creatinine ratio, hemoglobin A1C, and the baseline medication show advantage in the reduction in the renal-specific composite with consistent as well. So DAPA decreased the likelihood of patients deteriorating to a worse albuminuria category, with overall improvement in the clinical as well laboratory findings in the study. DAPA also increased the likelihood of patients improving in albuminuria category, regardless of the basal urinary albumin creatinine ratio, microalbuminuria or macroalbuminuria. And in sub-analysis, effect of DAPA on the development and progression of kidney disease in patients with type 2 diabetes, the DAPA showed that it seems to prevent and reduce progression of kidney disease compared with placebo in this large and diverse population of patients with type 2 diabetes, with or without established atherosclerotic cardiovascular disease, most of whom had preserved renal function. So what do the guidelines say, especially in the era of individualizing the treatment? So in patients with diabetic kidney disease and albuminuria, provided that estimated GFR more than or equal 30 milli per minute, with urinary albumin creatinine ratio more than 300 milligram per gram, regardless of the baseline hemoglobin A1C, DAPA has primary evidence of reducing chronic kidney disease progression. The KDIGO early identification and intervention in CKD consensus. 4 major topics were then addressed in selection of population, CKD screening, relative diagnostic and predictive characteristics, the evidence base for treatment that reduce the risk of chronic kidney disease progression, as well cardiovascular diseases, with implementation strategies for chronic kidney disease screening, risk stratifications, and the treatment program. Once diagnosed or confirmed CKD, we have to apply the risk stratification for staging and the prognosis and applying the effective treatment. So in these guidelines, persons with hypertension, diabetes, or cardiovascular disease should be screened for chronic kidney disease. And a CKD screening and treatment program should also be implemented in high-risk group. With a sodium glucose transporters inhibitor is recommended as first-line treatment with metformin in patients with type 2 diabetes, and may also be benefits in persons with CKD and no diabetes. While it should be initiated if GFR equal or above 30 ml per minute and can be continued through estimated GFR below, still not indicated until dialysis initiation, at which should inhibitor discontinued. So the KDIGO early identification and intervention, controlling all the metabolic profiling of the patient, including hemoglobin A1C, controlling of the systolic blood pressure below 120, controlling of hyperlipidemia, using of sodium glucose cotransporter inhibitor is recommended as first-line treatment for those patients to slow down the progression. The case for early identification and intervention of chronic kidney disease, improving global outcomes, controversies conference, with a consensus emerges that CKD screening coupled with risk stratification and treatment should be implemented immediately for high-risk persons. In the publication of the Dapagliflozin in patients with chronic kidney, with DAPA-CKD trial assisting the DAPA in over 4,000 patients with CKD with or without type 2 diabetes, excluding patients with polycystic kidney disease, lupus, and immunosuppressive therapy using 10 mg of DAPA with an endpoint either decline in GFR more than 50 or equal 50% of the estimated GFR, heart failure, cardiovascular death, and all-cause mortality. With a diabetes status, 67% was diabetes, type 2 diabetes, and kidney disease for those patients around 58.3% with a diabetic nephropathy. With 58% of population enrolled in this study has diabetic nephropathy, while those patients with diabetic nephropathy by testing showing that 86% have pure diabetic nephropathy, and the majority of them, but a little percent has non-diabetic nephropathy, and in this include ischemic hypertensive nephropathy or chronic glomerulonephritis. The results is showing that superiority of DAPA over the placebo in the primary composite outcome with a significant results, while decline in estimated GFR of more than 50%, as well end-stage kidney disease, are non-significant. The DAPA significantly slow progression of kidney disease and reduce the risk of adverse outcome with a sustained more than 50% of estimated GFR, end-stage kidney disease, or cardiovascular risk. With a significant effect on the composite of endpoint of cardiovascular disease, death or hospitalization for heart failure was consistent with the previous DAPA trials. It also demonstrated a significant marked reduction in death from any cause, and there was a numeric reduction versus placebo regardless of dialysis, with overall 31% reduction in relative risk reduction. And here it's summarizing the statistically significant treatment benefit was demonstrated in DAPA-CKD across primary and secondary outcomes, with a well-tolerated, consistent with its established safety profile for the drug treatment. And republished in the Lancet, with the DAPA reduced the risk of major adverse kidney and cardiovascular event and all-cause mortality in patients with diabetic as well non-diabetic chronic kidney disease. So to summarize the DAPA-CKD study, the overview of DAPA against placebo with 39% relative risk reduction, both in patients with type 2 diabetes as well as patients without type 2 diabetes, with a high safety profiling. Adverse event rarely lead to discontinuation of the treatment, and the trial stopped early due to overwhelming efficacy. Results consistent in patients with or without type 2, and the first renal outcome study to show robust benefit on all-cause mortality. We demonstrate the ability to prevent and to treat cardiorenal complication across the spectrum of diabetic kidney disease severity. So DAPA-CKD is a promising and to expand the cardiorenal benefit of DAPA to patients with CKD. Thank you very much.